again, and welcome to another one of our videos from the Accreditation Readiness Network, and a discussion about the new process that the Joint Commission has introduced here for 2026 called Accreditation 360. So this is the fourth video in a series of videos. It's actually part 3 of a series of videos. But this is the fourth overall about the topic of Accreditation 360. If you're interested, if you're brand new, welcome. We're excited to have you here. If you want to get caught up, you can just go to our website, and there's a banner at the top. Click on the link, and the previous 4 videos will be there, and we invite you to watch those and provide your feedback. And for those of you who are joining us live right now, you'll notice some of our team members are in the chat room and eager to engage in conversation with you. So please feel free to ask your questions there, and we'll certainly respond to them. So we're continuing this series about the process guide and the process in general, because it's changed fairly dramatically, I think is a good way to say it, going forward in 2026. And, I've heard a lot of folks say, well, there's really nothing new. Nothing's changed. The reality is I disagree with that to a certain extent. I'll poll my experts here that I'll introduce in just a second. But they technically haven't added anything new, although they did. But they really haven't reduced things very much. And in addition to that, they've rearranged everything. And so there's a lot to unpack here, and we'll continue to do that as we go forward. And we're going to have these videos every 2 weeks like we've been doing. So we invite you to come back. But today we're going to focus primarily on leadership and governance and medical staff. And so I've got my 2 subject matter experts in those areas. Howard Nussman, who's the principal here with the clinical team, and Dr. Edwin Lofton. I got to remember that. Sorry, Edwin, we got too far back for me to cut. It's hard for me to do that sometimes. But anyway, today's going to be a little bit more linear probably than the previous ones. We'll try to make it not so much, but part of that's due to me trying to cut back on coffee, so forgive me. So let's start out with you, Edwin, if you don't mind. So, the change with moving from chapters to modules, it's a little bit of a change, and there's a new module, this national performance goals. I promise you by 2026, I will not want to say national patient safety goals when RSE and PG, but national performance goals. So tell me a little bit about how the leadership module fits into that.
Glad to. As we know, there is one entirely new module, and we've discussed that in previous videos, and that is the NPG, the National Performance Goals. And what the Joint Commission has done is assimilated components of almost every other module into the NPG, including the National Patient Safety Goals, lots of leadership, infection control, nursing, and many other things. But what they've done in the right of NPG is they've incorporated components of the leadership or the LD standards and the EPs throughout the entire module. They've simplified on the surface, and this goes back to your point, Steve, of it's really not more simple. It's some wordsmithing that is caused there. They've simplified some of the wording in the actual standards and EPs, but what they do is push an organization to not look at the letter of the law, so to speak, in the Joint Commission standards, but you have to know the CMS COPs that are relative to that. And that's where the devil in the detail truly occurs. In reading the standard and the EP in the new A360 component, it may reference ancillary staffing and mixing and leadership accountability, but you've got to be able to turn that in the crosswalk back to the CMS COP that refers to that. So throughout the entire chapter of NPG, there are components of a leadership accountability, ownership, and coming back to one of the 2 new standards that do exist is the mission and vision and goals must be demonstrated in the actions of PI, and that is owned by leadership and the governing body, which Howard will speak to as well.
Yeah. So, I feel like we've said this many times, and maybe at the risk of being redundant, the COPs are the key to this. And Correct. In the past, I think it was safe to assume that if you were compliant with all of the standards, you were okay with the COPs, but with this change, you really need to be knowledgeable of this. I mean, you could get, I guess what I'm saying, you could kind of get away with not really having a deep level of knowledge on COPs, conditions of participation from CMS. Now you really need to, you kind of got to dig in there and understand the COPs a little bit better. Is that a fair statement?
Very fair statement. And I think it's well stated in that Joint Commission is taking away their ownership of feeding you an easy breakfast. They're making you go harvest the wheat to make your own biscuits, and you got to know where the wheat's grown, and the wheat is in the CMS COPs, conditions of participation, or in facility standards, in ASHE standards. The Joint Commission has changed their language that puts the ownership of the critical detail knowledge on the organization itself. There's no more cliff notes.
I'm grinning because it's obvious that Edwin grew up on a farm.
I was going to say,
and you're also making me hungry right now.
Interesting analogy.
I know. If you knew Edwin as well as I do from way back, you know that's exactly where that came from.
I'm hungry.
Yeah. So, well, what section specifically of the NPG, the National Performance Goals, is affected by the leadership chapter? Or
so there is one standard that has more focus with leadership than all of the others. While LD is seeded throughout, it is one standard and several EPs that is really focused on, and that is NPG 12.02.01. And that reads, and I'm going to read it specifically. The hospital's leadership team ensures that there is qualified ancillary staff required to meet the needs of the population served and determines how staff function within the organization. Now, a quick read of that sentence says, okay, you got to have the right people. Okay, fine and dandy. The detailed read of that is really look at the detail of the words. Ensures that there is qualified ancillary staff. They go on and define ancillary staff as diagnostic radiology, dietary, emergency, medical records, nuclear medicine, nursing care, pathology, laboratory, pharmaceutical, physical rehab, respiratory care, social work, and operating room. And they go through that. Then the second component of that title is to meet the needs of the population served. And they expect you now to be able to define through your community needs assessment, remember that term, who your population is. They do not want you to serve the population of the United States. They want you to serve the population of the county, the city, the neighborhood where your population comes from. So understanding and Howard will probably speak to this, understanding the health equity within the population, the mix of the population, the how wealthy or poor the population is, what type of diseases they have. You've got to do that in designing your ancillary services. As I said earlier, the devil gets down into the detail, and when you read the standards and the EPs of 120201 and 120101, it actually relates to, and I'm going to read again, excuse me, 482.23, nursing, 0.24, medical records, 0.25, pharmacy, 0.26, radiology, 0.27, lab, and I could go on all the way through 0.51, operating room. And the detail within those COPs defines the leadership responsibility for assuring the right mix, the right skill set, the right educational preparedness, and a way from your PI systems to prove that mix, education, and volume of staff is adequate for the population you're serving.
So let me ask you, if you were back in your previous position as a chief nursing officer, how would you approach this? What would your feelings be about this? I guess as a starting point.
I'll take the luxury of sitting in the chair that I am right now. They finally got it right. Now I'll jump back into the chair of a CNO. Oh my God, I'm going to be held accountable to really be able to define what we're doing around here. So again, this goes back to the new standard within NPG, which is the mission, vision, and goals of the organization. must drive the actions of the organization. If I'm going to run a radiology department, what are the components of the radiology department? Is it just general rad? Is it mammography? If you're doing mammography, why? Is it because the population that you serve has a higher breast cancer rate, or has a lower screening rate? And the leadership staff, the leadership of the organization must understand why you chose to run that mammography department, or why you chose to run a radiation oncology unit, and define that through the mission, the vision, your PI plan, and your community needs assessment. So that the knowledge of who you serve, how you serve them, and are you doing the right job is essential to the leader.
Awesome. So let me get Howard in here. He's been sitting there patiently for a while now. So what do you see in the new survey process guide modules that people ought to be really paying attention to, specifically around governance, but whatever comes to mind?
Yeah, so let's take a look at the governing body, the governance module, and just to kind of build on something that Edwin was saying. So there's nothing new. Just a very few things that are new requirements. But just as we're going through this process of trying to understand what's in that survey process guide, and very specific instructions to surveyors that, of course, looks like a state operations manual appendix A from CMS. The people who are going to be surveying for the Joint Commission are also going through that survey guide and trying to understand what they're going, and it's clicking in their brains things they're going to have to do different, that look at things that they haven't looked at before. So what I want to do for a few minutes is, as I went through the governing body module in the survey process guide, I was looking for things that, just might be stumbling blocks, and, things that could be problematic. So, and Edwin, I'm glad you brought up about like health equity, which is in the national performance goals, or workplace violence is another example. When you go through the modules for governing body and for medical staff, you don't see a single mention of those very important, components of being accredited by the Joint Commission. These national goals for performance, where we're trying to raise the outcomes, improve the outcomes, and just sort of raise the level of performance across our industry. You don't see those in these modules because they're driven by CMS, and so it'll be our task, and in the hospital, each person's task to just say, so how does this very, very specific CMS do this when you're surveying a hospital? How do we integrate and incorporate health equity or workplace violence? Or once we've got more information about those NQF measures on maternity care and hip and knee procedures, or spine or cardiovascular procedures, then we got to figure out, so how do they fit together? But let me just sort of give you an example. So one of the things that stood out to me in looking at the governing body module had to do with if your hospital is part of a multi-hospital healthcare system and you have a single governing body. So and this is very common, I would say most of our clients fit this model or are moving into that model, where you have a single governing body and 4, 5, 6, 15 hospitals that are separate Medicare provider numbers. So in the surveyor guidance, in the survey process guide, is very, very clear. Surveyors are to verify that when that board meets, that they consider and that they have actions that they take specific to hospital A and specific to hospital B and to each one of those Medicare provider numbers. And I think, based on lots of years of going in and reading board minutes, as all this has developed, the person who's preparing those minutes isn't necessarily reading the survey process guide and understanding that if the board takes specific actions, let's say an example being with health equity, um, each of those Medicare provider numbers has to have someone that is their leader in this initiative. Now, it could be the person who lives at the corporate office. But they say, so how much time does that person spend here at your hospital? But more importantly, each of those hospitals has to have its own understanding of, so what's the priority? What are we going to work on here in this hospital to reduce healthcare disparities? And we work with systems where they've got an urban, downtown medical center, and it has very different healthcare disparities from 30 miles outside town in a bedroom community, very different population and different disparities that they should work on. So
Right.
the guidance in this CMS driven manual is you have to look to be sure that actions taken, are specific to this Medicare provider number. And then because none of the others matter during survey. It's just your hospital. And so they're going to look for documentation in those minutes that will be specific. And I think some organizations do that well, and some still struggle with, so how do you find the board's actions specific to each of the facilities?
And Howard, that reinforces what I was just saying about NPG 12.01.01, population served to the Medicare number. So again, it goes back and ties back to each individual organization, as you were just emphasizing, must define their population very specifically.
Mm-hmm. Yeah. And, another very common example of the board taking action is the medical executive committee recommends the privileges and recommends, the physicians who are being reappointed or physicians who are being appointed for the first time to the medical staff. And it's very clear that it's the board who makes the final decision. And so when you are looking for the evidence that the board took action on this list of 50 providers who were reappointed last month, you should be able to see in the board's minutes that, okay, we discussed for hospital A, these physicians, and we're accepting the recommendation and approving the recommendation made by the medical executive committee. And you can tell who those, probably in an appendix to that set of minutes, but here's the list of all those people. And certainly, so every now and then there should be some questions, and
Yeah.
and a real trap that I see, it's in an effort to be efficient. There are a lot of consent agendas where a huge box of materials go out to each board member to read the week before the meeting. And there's a lot of just sort of approving. Yeah, we accept this. And if you get into that, as everything becomes that way, then you lose any kind of actions being taken specific to a particular facility. Were you going to say something, Steve?
Well, I'm going to ask an ignorant question as the token physical environment person on this one. Um, you touched on something. You mentioned the downtown hospital and then the suburbs, but in my mind, I immediately went to models that we have with clients all around the country and more. There's a metropolitan, there's sometimes a university system, and then there's a bunch of rural hospitals that have been
Very
associated
different. Yeah.
dramatically different, right? So when you think about, the push being for that same standard of care across the organization, I mean, that's a little bit complicated by the fact that the needs of the community 50 miles away in a town that's 3,000 population or 2,000 population is dramatically different than the needs of the community in the university town that maybe 150,000, right?
Mm-hmm. Yeah.
So this is where that kind of fits in, is we're addressing it as much as possible the needs of that specific hospital is 2,000 people in that community.
Mm-hmm. Yeah, absolutely. And that will also come into play when we get into some of the medical staff things in terms of quality of care. Um,
Yeah, so let's jump right into that if you
I'm
don't
not quite
mind.
well. Let's. I got a couple of other things from the governing
Okay,
body. All right.
sure.
And I think it's extremely important to understand what all these requirements are for the governing body. And I think because as the standards point out, and I can't quote the specific reference number, but the governing body, I mean, the buck stops with the governing body. They are ultimately accountable for the quality of care being provided in the organization, as executed by the medical staff and everybody else. And so we saw it for a while. A few years back, there might have been some push by CMS to cite leadership more often when there were things that were not compliant, and we saw that happening in some surveys, but not so much that I have noticed lately. But I think we will begin to see, just like in CMS and state surveys, that the first thing that gets cited is governing body not being accountable for and providing for safe patient care, or however they might state it, because of citations then on down through the report. So I think we'll start to see in 2026 more board citations, and just calling out and saying the governing body is accountable for the care in this hospital. And now let us tell you what's wrong, you know.
Yeah,
And so I think it's something that they need to be prepared to understand that. Um, Something that I thought was interesting is in the governing body module, it says for the surveyor to interview medical staff leaders to verify that they apprise the governing body of the medical staff's evaluation of patient care services that have been provided hospital wide, which is a mouthful. But it's basically saying, and it should be periodic. So every now and then, the medical staff leaders are supposed to, be evaluating the quality of care across the organization. It says at every patient care location of the hospital, and keeping the board apprised of how are we doing.
yeah.
You wanted, you look like you wanted to
So,
say something.
well, no, I was. I'm sorry, I got choked up there. I was going to ask because you're talking about how important it is for the governing body to be involved. More so, I mean, it's always been important, but the way I'm reading what you guys are telling me right now is it's way more important next year than it's been in the past. Is that fair?
Hmm.
Yes.
So one of the
It's
ideas,
not more important. It's just that I think in the maybe in the spirit of wanting to be good to the board, being kind to them, be respectful of their time or whatever, that we kind of boil everything down to very simple statements,
right?
so we don't take all night to discuss the state of the union. And
Yeah,
but it is important that they understand the state of the union, and that they participate in asking questions of a report that comes up on quality and safety, and say, well, okay, tell me more about that. Why, if I've got four hospitals and your hospital looks like this, why is your data so different? And asking questions, and and maybe imagining, what would I tell a joint commission surveyor if they come and ask me that question as a board member? Do I
yeah.
know enough to be able to answer?
Well, I'm glad you asked that because one of the ideas we've been beating around is doing a series of short videos for executives
Hmm.
and
Hmm.
C-level, board level people about this process change. So for those of you all that are here today, if you would put in the chat if that's something you're interested in and would have found value in, we'll start putting those together. An idea popped up in one of the previous videos that, hey, maybe we need to start doing some shorts, if you will, to borrow a phrase from TikTok or whoever it is, and do help them understand how this is going to affect them.
Hmm.
So
Yeah.
if you would let us know.
Yeah.
Um,
So,
what? Yeah, go ahead.
well, I was going to say, and then just kind of related to that, in a similar vein, there's a leadership standard, and I do have this reference number. It's 110101 EP5. Says that the governing body consults with the individual responsible for the organization and the conduct of the medical staff or his or her designee. So that would probably be the president of the medical staff,
Yeah,
periodically. Um, and the surveyor guidance says verify that it is periodic, and it says at least twice a year. You have members of the board meeting with the president of the medical staff or designee, and it's documented. They suggest look for agendas, look for minutes, look for who are the attendees. Um, and they say, and I'm put quotes around this, that they discuss matters related to medical care. So it can't be about,
golf.
any. I didn't want to say that, Steve. It can't be about politics or, the country club or anything. It has got to be about matters that relate to medical care. Um, and it also, the guidance advises the surveyors to look for the policy and the procedure that describes how this process takes place. I
And
have
just for
never
clarification,
seen that. I have
yeah,
never seen that come up in a survey before.
interesting. Well, and just for clarification, this is members of the board, not the board. So you don't have to, if you had a 20-member
Correct.
board, right, you could have a 5-member subcommittee that's responsible for doing
Hmm.
this. And that would be
Hmm.
that.
Yeah.
That
Or usually there's going to be like someone on the board who is the chairman of the board quality committee, or it could be the board quality committee, which is just a small group. But just, if you go back to and think about, so one board and multiple medical staffs, because you have multiple hospitals that are surveyed separately and their separate medical staffs, that's a lot of getting together and talking about the state of the union
yeah, it is.
between the leader of multiple medical staff. Now, you could meet together, but you would want to be very careful about making sure that each medical staff is discussing what's going on at their facility, and
Yeah.
so it's it was it's been in the standards for a long time, but no one ever talks about it. And I doubt that Joint Commission surveyors have thought to look for it. Last thing on the governing body, contracted services. Just quickly, I mean, now, hallelujah, they're less prescriptive. They took out the wording about leaders have to determine the performance expectations and communicate those in writings. All that's gone. But the first thing it tells the surveyors to do about this is to look for the organization's policy and procedure about how they evaluate the performance of contract services. And if you continue doing what you've been doing, they're going to expect you to keep that. That's what they will see when they're on site. And I'm just
Yeah.
saying, I think we have an opportunity to redesign how this process of how to evaluate contract services, um, and then write a policy that maybe has a more a more streamlined approach and one that is more integrated into your overall QAPI process.
I was
Because
going to
the
ask you about if you had kind of a framework in mind for that. Certainly, data would be an important part of that evaluation, I would
Mhm.
assume.
Yeah, and in fact, in the guidance, it says it asks the question: are the hospital using QAPI principles in their evaluation of the contract services? So to me, that's a hint that don't create a separate process. Just make sure that, as it is required, that dialysis contract service is tied right into the QAPI process with every other department of the hospital, um, and does a good job with measuring and reporting out on what their safety and quality and customer satisfaction, whatever, all these things, how that looks, and say, and this is what we're working to improve as far as processes that are problematic for us. And I think, that would just let QAPI be the engine for it. But you're going to have to change what you say in your policy about how you do that to reflect that.
Yeah.
And just to be sure everybody's aware, there is a requirement for a list of all the contracted services. CMS has never limited that to clinical contracts. The hospitals that I know that went through full CMS survey, they had to give the list of all contracts. Now, the
Yeah.
focus, of course, is on patient care, but you might want to begin thinking about how do we get a list that's complete for all contracts.
Well, and there's so many that affect the non-clinical components. I mean, there's not most hospitals, but a lot of hospitals outsource medical equipment management, outsource facilities management. I mean, just as a litany of things that environmental services is another one that comes to mind, food services. So that's, I'm glad you brought that up, because you would
Mm-hmm.
think that there would need to be a mechanism in place
Absolutely.
to make sure all are the way they are, or should be.
Yeah, absolutely.
So let's talk a little bit about the medical staff.
All right.
If you're ready to.
Yeah. So, kind of interesting thing with the medical staff, they did not take any of the medical staff standards and incorporate them in the NPGs like they did other sections of the accreditation manual. So medical staff still has its own chapter. But again, there's nothing really new there. They just have, I think surveyors will be taking a fresh look at how do I survey what's going on in the medical staff, because of all the very specific guidance that it comes out of the CMS requirements. So something that is not new, but would get close attention certainly is if you've gone through the process, and some have, of creating a unified medical staff. So this is different than a single board. Well, it's similar to a single board in that instead of having, if you got 6 hospitals, 6 medical staffs, you have one medical staff that serves all 6 hospitals. So for one medical staff, one set of bylaws for all of those CCNs, one credentialing and privileging process. And so if you look at, so what are the surveyors told about unified medical staff? What should they look for? It's that you apply the bylaws and the credentialing processes and other processes consistently across all of those hospitals. Like, so you were mentioning some of our clients, you got the big university medical center, an academic medical center, and then these rural hospitals that surround it. Very, very different, but you're going to have to look for, as applicable, consistency in how they carry out their credentialing and privileging, which probably is not as big of an issue as maybe things like ongoing professional practice evaluation or focused professional practice evaluation when you get off in a remote site that's different than where all the resources are, at the larger medical center. I would encourage you, if you have a unified medical staff, to look closely at that and notice that they also pay a lot of attention to giving the medical staff members the ability to, at some point, if they say, this unified medical staff is not working, to opt out of it, and having a process for people to raise that question and to be able to opt out, not individually, but to say, for our hospital out here, this just isn't working for us.
Yeah, I mean, sometimes it's difficult to fit. Every one size doesn't always fit all, I guess, is the
Mm-hmm.
what I'm wanted to say. So,
Yeah.
anything else you guys want to add? We're trying to keep
Um,
these at 30 minutes. We're getting close to that now. So,
Yeah. Well, let me just, at least for people who are in our accreditation readiness network and have access to the yarn, there is a really good session on there that one of our good friends over in Carbondale, Illinois, at Southern Illinois Health, they shared their story about going from a 2-year to a 3-year credentialing process,
yeah.
which is certainly allowed if your state allows it. Not every state does, but I would encourage you to take a look at that. And if you're not in the ARN, if you have questions about that, to feel free to reach out to me, and Edwin would be happy to share information about doing that, how you do that. And telemedicine, just as a reminder, it's been a long time now since that was a big, it was this huge new thing that happened all of a sudden in medical staffs and in healthcare, where we began to use providers on the other side of the world over in Australia, to read radiology reports and stuff like that in the middle of the night. And so CMS put together a lot of requirements. I would encourage you, if you have not looked at those contracts in a while, that you look at those contracts and that you also review what's in the guidance. But one of the things that it says, two things that I think are important. One, if you are using their credentialing and privileging process, which you can, did your governing body say that was okay? And have you tested that to be sure that their process complies with the Medicare conditions of participation? Very important. And secondly, and I don't always see this when I go into a hospital, it's the question that surveyors are told to look to see that the provider of telemedicine services has given the hospital a current list of all the practitioners who are currently providing care to their patients with pertinent licensure information and a list of their current privileges. And I think some of these organizations are so big with so many providers, and they're turning over. And how do you know which one is providing care at XYZ hospital?
It seems almost impossible, but
Yeah,
yeah.
it does. And I think surveyors are going to think, I'm going to go look for that because
Yeah.
they like to have findings. All right.
Yeah.
So,
Awesome. Well, I'm glad you mentioned the Accreditation Readiness Network, because I was going to remind everybody that those that are members will get CECs for this.
mhm.
You need to apply for them or whatever. So by zero point 0.5 units here for this one. So make sure you take advantage of that. We will be doing another video in 2 weeks. So we appreciate you guys joining us today. And Howard, Edwin, I really appreciate your time and expertise. And
I'm glad
you
to
guys have
do
been
it.
digging in really hard here lately on this stuff. We appreciate it. So we're excited to take this journey with you going forward into 2026 and beyond. If there's anything we can do, please reach out to
Oh
us.
yeah, I'd love to come and take a look at your list of telemedicine providers. Yeah.
Yeah. Yeah. Sounds like a fun Friday afternoon, Howard.
Yeah.
So, well, with that, I will say goodbye and thank you very much.